evidence-informed management of conditions which commonly present to a naturopathic clinic, and diabetes would definitely be one of them. A lot of my work revolves around research, both clinically and academically. I'm also currently a co-principal investigator in an integrative diabetes trial, which gives me the opportunity to work with other family doctors as well as the local hospitals. So that's all very exciting. My contact information will be on the screen at the end of the presentation, and if anybody has any questions, feel free to contact me, and email is probably your best bet. Okay, so one of the things that I was kind of asked to share is why I picked naturopathic medicine. And as, you know, maybe cheesy as this might sound, I do think that everything happens for a reason. I always knew that I wanted to get into healthcare, but I knew that conventional medical model didn't fully resonate with me. I studied biomedical sciences in university. I did a major in biology and a minor in psychology, and I knew that I had always wanted to do something that would combine the two of those. I really wasn't sure which career path to pursue, and I decided to maybe look into optometry. However, on the day of the entrance exam, I was kindly asked to leave the exam hall as the name on my university records did not match the name on my driver's license, and it came down to the fact that one of the records had my middle name and one did not. I was very frustrated and very angry at that situation because not writing the exam at that moment meant that my application to the School of Optometry would be delayed by a whole year. In the meantime, I figured I would start searching for something else, and it was I was in the professor's office accepting a placement into a master's program when naturopathic medicine was introduced to me, and as soon as I looked into it, I knew that this was the right fit for me, and I definitely have not regretted it since I've made that decision. Okay, so to talk a little bit about diabetes, it is definitely a worldwide concern. 1 in 10 or 11, depending on which resource you look at in the year that it was published, 1 in 10 or 1 in 11 people worldwide have been diagnosed with diabetes, and definitely more than that are living not knowing that they have diabetes. This number is 1 in 8 in North America, and these are the latest stats from the International Diabetes Federation. So this was 2015. I'm going to guess that that number has increased by now. Diabetes tends to also affect low and middle income countries more. They may have harder access to fresh foods, lower education, they may not have time to exercise, having multiple jobs, no time to cook. All of these things play a role in the prevalence of diabetes. One of the things that I really want to draw your attention to is that diabetes it's one specific condition, but it has a lot of different comorbidities, and one of them is depression. And so the stats basically indicate that about 30% of people with diabetes have clinically relevant depressive symptoms, and those people who have depression have approximately 60% increased risk of developing type 2 diabetes. Now, there's many, many reasons why these correlations may exist. Realistically, you know, there's probably biochemical reasons and lots of that, but I really do believe that in people who do have depression, it is difficult for them to make lifestyle changes or adhere to healthy lifestyles. Poor dietary habits, poor exercise habits can lead to both depression and diabetes. And if a patient has diabetes and they're also depressed, it's really difficult to motivate them to make those changes. And so it really does require the practitioner to be mindful of this and remember that you should always look at whether your patient with diabetes also has depression, and make sure that is also well managed. I only have the Canadian statistics for this, but about 33% of Canadians with type 2 diabetes don't feel comfortable disclosing their diabetes to others, and this is for a variety of different reasons. We know that about a quarter of Canadians with diabetes indicate that their treatment adherence is affected by cost. Now, in Canada, we have a public healthcare system, and different provinces cover different amounts, if you will, with respect to managing diabetes, but kind of nationally, well, nationwide, we're looking at Canadians who have to pay more than 3% of their income yearly for needed medications, devices, and supplies out of their own pocket. And it contributes to patients kind of feeling like, well, I don't want to spend money on it, so maybe I won't test my blood sugar and I won't pay for the strips. Or, you know, I have other things that have come up that are more important, and maybe this month I'm going to cut down my medications by half. So these are all things that as a clinician, you want to make sure you address and look at to help your patient understand why they have to adhere to medications, or understand why they have to test their blood glucose, and reinforce that these are important factors. All right, so preventing and treating diabetes with naturopathic medicine. So in my opinion, diet and lifestyle are definitely the cornerstone of treatment and should be implemented in every patient with prediabetes or a diabetes diagnosis or at risk of diabetes, regardless of what other treatments the patient may be on. And there's different treatment options, obviously. We have pharmaceutical drugs, herbs and supplements. Patient education is, I think, an area that naturopathic medicine really will excel in. And this is because I'll discuss a case with everyone later, but one of the things that a lot of my patients come in and say they've been told to change their lifestyle. They've been told they have to exercise. They've been told they have to eat well. And if your patient is kind of very far from that ideal, it's very difficult for them to make those changes. And they don't always understand why. They don't understand how to do it. And I mean, let's face it, if your patients go online and look up what a healthy diet is, there's all this information out there, and it can be very overwhelming for patients. And so it's part of our duty as naturopathic doctors to make sure we spend time with our patients to educate them on really how to manage their diabetes. And then the other thing, as I mentioned before, was making sure that we prevent and treat comorbidities like depression. Okay, with respect to diet, my students laugh about this all the time because they say that if I have a question on my exam that asks about diet, if they put the Mediterranean diet, if they don't get full marks, they will at least get part marks. And it's true, not because I, particularly have a fondness for the Mediterranean diet or anything like that, but it really comes down to the fact that in all the studies that have looked at a variety of diets, the Mediterranean diet really has the most consistent health outcomes. It has been demonstrated time and time again to lower the risk of diabetes. It reduces the use of medication, even if you are diagnosed with diabetes. It improves mood, and it lowers HbA1c. So HbA1c is glycated hemoglobin, and it's a measure of the average 3-month glucose concentration in the blood. And the reason why it's a 3-month measure is because we're looking at red blood cells, and the lifespan of a red blood cell is somewhere between 3 to 4 months. We know that if we take the Mediterranean diet and reduce the carbohydrates a little bit more, it can even better improve health outcomes and parameters. The good thing about the Mediterranean diet is that it has been studied across many different cultures, which means it can be culturally adjusted, and that's a really important thing. A lot of times in North America, diets are looked at and examined and designed to fit the typical North American diet, or somebody who lives in North America for a really long time. But the thing is that people who have specific cultural preferences for food, or they've immigrated and they haven't really kind of merged in with the typical diet for North Americans, it could be hard for them to switch. I will give you an example. My background is Chinese. My family's very traditional. I actually grew up here, but my family is still really I wouldn't even say adapted. They're still very focused on eating a traditional Chinese diet, which means that there is a lot of rice. And so if you were to tell my family member, and my grandmother has diabetes, so if I told her not to eat rice or switch even from like plain white rice to brown rice or anything like that, she would find it difficult. And so part of this is being understanding of that and being able to examine with your patients how we can adapt the diet to still be healthy and also fit their cultural needs. The other thing about the Mediterranean diet is that it really doesn't take away the fun from eating, which I think is another thing that is really, really important. And this is because eating in our culture is it's a very social activity. And so you really don't want people to feel like they can never go out and eat with their friends because they have so many restrictions. So what does the Mediterranean diet look like? Okay, so we have greater than 3 times a day. You want to make sure you have fruits and vegetables, and I would say not the starchy vegetables because that kind of counts in another category, and then lots of olive oil. Greater than or equal to 3 times a week, we're doing lean protein. So that the Mediterranean diet actually focuses a lot on fish and seafood, but definitely lean protein, lean chicken, lean turkey would fall into this category. And then it is encouraged to have at least a handful of nuts and seeds, and you definitely want to tell your patients that it's kind of the raw, unsalted nuts and seeds, and if they chose to add some spices to flavor it, that's fine, but you don't want them to have like the really flavored nuts and seeds because that tends to add a lot of sodium and preservatives, and depending on what flavor, sugar and fat as well. So you kind of want to encourage your patients to buy the raw ones, and then they can roast it with a little bit of seasoning if they would like. And then less than 3 times a week, we're having grains and starchy vegetables, and then 1 time a week, we can have some dairy, red meat, and I apologize, I didn't pick a very good picture for pastries, but that's supposed to be a Danish of sorts. Then the really fun part, I guess, is you still get to have a glass of wine per day. And this is very related to the Mediterranean culture, but in all the studies that have looked at the Mediterranean diet, having wine in moderation has not led to any detrimental outcomes. So we still encourage it because it's part of the diet. Okay, so aside from diet, exercise is also really, really important. We know that exercise decreases the rates of mortality and cardiovascular disease. We know that exercise will decrease the risk of neuropathy, which is a complication of untreated or long-standing diabetes. We know that exercise will help your patients improve their mood, and it also improves specific measures related to diabetes like the HbA1c and insulin resistance. Okay, so what kind of exercise and what constitutes exercise? One of the things to remember is that sometimes when you tell patients they have to exercise more, they immediately get this image of doing really long runs and getting all sweaty, or running on a treadmill, or they have to go join a gym. And that might be a preference for some people, but it doesn't have to be that. Any of these on here on this screen would count as good forms of aerobic exercise. So going for a brisk walk with friends, or maybe during their lunch break, cycling, dancing, swimming is another really good one. Playing tennis or any other sports is another option. Obviously, jogging is still a preferred method for a lot of people, but it may not be for your patient, and that's completely okay. It's as long as they stay active. Hiking and skating all are good examples of aerobic exercises. Now, we want to balance aerobic exercise with strengthening exercises, and this could be It could be working out in a gym or on machines. It could be using resistant bands at home. Weights at home is also another option. Patients, especially elderly people who don't necessarily want to buy weights or feel uncomfortable using heavier weights, I've had them use soup cans, and that's an easy thing that people might have at home. Squats is another option, making sure that you're doing it correctly so you don't hurt yourself. Planks as well, and then also heavy gardening would count. And the idea is get your patients to stay active. Depending on which source or which guideline you read, it'll be phrased a little bit differently, but at the end of the day, it kind of comes down to at least 150 minutes per week, or at least 30 minutes 3 to 4 times a week. And the idea is to get your heart pumping a little bit. You should be sweating a little bit, but you shouldn't necessarily have to be out of breath. And you do want to ask your patients to have a good distribution of both aerobic and strength training. Okay, so pharmaceutical medications, there's many different classes. I don't want to read through this whole slide for you, because I think you can kind of do that on your own. But I would say the most common is the biguanides, and the one that you'll probably hear the most of from there is metformin. But basically, each of these medications have a different way of helping lower the blood glucose level, and then lower down, and usually we try to exhaust the oral medications first, and then, if necessary, we'll add insulin. Although this is now starting to shift, because there is some evidence that maybe adding insulin in a little bit earlier can be helpful for the patient. The bile acid sequestrants, the second to the bottom, it lowers LDL, which is the quote-unquote bad cholesterol, and it for some reason also lowers glucose, and it's by an unknown mechanism. But sometimes doctors will prescribe this if the patients have both diabetes and cholesterol. Okay, so you're giving your patient, diet and exercise, maybe even herbs and supplements, and pharmaceuticals, in combination. At the end of the day, you kind of want to know, well, how much is enough, or should I be doing more? And the way you want to look at this is measuring the HbA1c as a target. Now, even maybe 5 to 10 years ago, it was always get everybody under 7, closest to 6 is the best. We're starting to realize that there needs to be a little risk-benefit analysis. The benefit being, of course, lowering the HbA1c, which confers a better long-term outcome for your patient, but then there's also the risk of your patient having hypoglycemia, which is lowering the blood sugar too much by using too many interventions. And so basically you want to figure out your patient's kind of baseline health status, what the goals are, and then tailor a target HbA1c for them. The good thing about technology now is there's a lot of free online calculators that will help doctors decide what target best fits their patients. And so you would just look up these information. I know that the Canadian Diabetes Association definitely has an online calculator, and you basically go in and it asks you a bunch of questions, and then you answer them according to your patient's health status, and it'll tell you where you should be targeting on the spectrum for your patients. Okay. A variety of herbs and supplements to choose from. Momordica is bitter melon, and we've seen some evidence that shows that there's a small improvement in HbA1c, and the OGTT is the oral glucose tolerance test. So there's a lot of, originally there's a lot of studies that looked at the extract of bitter melon, so in a capsule form or a tablet form, and now we're noticing that it looks like bitter melon seems to be more effective if you're drinking it in juice format. And now I don't know if anybody here has ever tried eating bitter melon or drinking it, but it's definitely named that for a reason, and not everybody likes it. But if your patient is okay tolerating some bitter melon juice, then this might be an option. Cinnamon is easy, I guess, in a way, because you can have patients incorporate it into foods, and it also lowers HbA1c and fasting glucose. And there's some evidence that in patients with type 2 diabetes, adding cinnamon to their diet will also improve their cholesterol panel. And so that's the LDL. The TG is triglyceride, TC is total cholesterol, and HDL is the good cholesterol that you want to increase. Gymnema is another herb. Now this one's really interesting. It lowers the HbA1c, but it also blunts your taste to sugar. And this is an experiment I do with my class for any of the students who want to participate and don't have other health concerns. What we do is I'll get them to chew a tablet of gymnema and let it kind of coat the tongue a little bit, and I'll have them eat candy. And what they'll all notice is that you can only, you think you're tasting it a little tiny bit, but it's actually the fact that you can smell the candy as you're chewing it, and it essentially blunts your taste to sugar. So the one that I most commonly test out with is fuzzy peaches, and I say that like I assume that they have this in the States, but I'm not 100% sure. I'm learning that there's candy and chocolate that is only in Canada that we think is very common, but is not in the States. Fuzzy peaches are peach flavored, and they're kind of coated in sugar. So I'll have the students eat one first. They'll all taste it, of course. It's very flavorful. And then we'll have them chew the gymnema, and then we'll have them eat the fuzzy peach again. And it is a night and day difference what you can taste. So at the end of the day, gymnema may be helpful because it kind of reduces the intake for the patient. So it may help them if they're willing to take it before they kind of eat something that's very sugary. It may blunt it, so therefore it makes the patient kind of want to have less of it because you don't really get that sugary feeling. However, at the end of the day, your patient is still eating the sugar, right? So I would say use this one as an option, but you'd probably want to combine it with other things. We have the Coptis, which is Chinese gold thread, and again, it lowers HbA1c, fasting glucose, and it seems to have a little bit of an effect on improving the cholesterol panel as well. HOMA, the HOMA, it stands for homeostasis model assessment, and it's a measure of insulin resistance. I would say it is uncommon for clinicians to run this as a measure, but it is used a lot in research. Curcumin or turmeric can lower HbA1c, lower fasting glucose, improve triglyceride, and also the HOMA measure. Soluble fiber is an important one. There are studies that demonstrate diabetics actually need more fiber than somebody without diabetes. So definitely encouraging that they eat lots of fruits and vegetables that have fiber. And then occasionally I've seen NDs use a fiber supplement as well that can lower HbA1c. Ginger is another good one. It will improve a very small improvement in HbA1c, but it will improve the HOMA measurement. Resveratrol, which is found in red wine, can also lower HbA1c and improve the cholesterol panel. Magnesium is a newer one, actually. It does lower fasting glucose and lowers HbA1c. A lot of the studies, though, basically point to having high magnesium in the diet as opposed to supplementing with magnesium, although there are some studies that have looked at magnesium supplementation for diabetics. And I would usually pick this if I think that there's another reason why the patient should also be taking magnesium. Alpha-lipoic acid is a common one to be used for patients who have long-standing diabetes and peripheral neuropathy. Okay, and so one of the things I wanted to kind of bring up again is to remind everybody that diabetes is one of the triad of cardiovascular diseases, the other two being high cholesterol and high blood pressure. It is very common for patients who have diabetes to have one of these two other conditions, or they're definitely at higher risk of developing it. So one of the things that you want to do is measure a patient's cardiovascular risk. And there's many free online calculators to do this, the most common one being the Framingham 10-year cardiovascular disease risk. So with all of my patients, I always do a disease risk, a cardiovascular disease risk, to kind of reinforce them. What does having diabetes really mean for you in the long term? Aside from the diabetes specific kind of end organ conditions that can develop, like retinopathy, so you know, eye concerns, neuropathy, which is damaged nerves, and then there's also nephropathy, which is kidney concerns. And so there's lots of conditions that develop because of diabetes, but then above and beyond all of those things, diabetes also confers a risk for things like stroke and heart attacks. So you kind of want to give the diabetes in context for your patient and kind of look at the overall global picture. Also making sure that being overweight and having abdominal obesity is also a comorbidity. And like I said earlier, making sure that you take a look and see if your patient is suffering from depression, and that also needs to be addressed. Okay, so case study. DB is a 52-year-old female. She presents to the clinic with type 2 diabetes and high cholesterol. Her type 2 diabetes was diagnosed 2 years ago, and at diagnosis, her fasting glucose was 11 millimoles per liter, which is Canadian units, and I believe that is approximately 198 or so milligrams per deciliter, I think, is the measurement in the States. And then the HbA1c was about 0.07, which is elevated. She was given metformin, 500 milligrams BID, which stands for 2 times a day. Now, her high cholesterol, she actually was diagnosed prior to the diabetes, and she was given a very low dose statin at 10 milligrams per day. Blood pressure is ever so slightly elevated, definitely needs to be improved, but not yet high enough to be medicated. Her height and weight, I've typed out for you, and her BMI is 29.8, which is in the overweight category. Her physical exam and blood work are otherwise unremarkable. She's on no other medications, no other supplements, doesn't have any allergies. She's a high school teacher, so quite busy, often takes marking home, has to do prep on the weekends, but she does have a supportive family and describes her social network as healthy. She does not smoke, isn't on any recreational drug. We did a 24-hour recall, and definitely not ideal. Very minimal fruits and vegetables, and we're talking, you know, the definition of eating vegetables is the tomato sauce on the pasta, which, you know, in all fairness, tomato is a fruit, but definitely we need more than that, and more variety. Minimal protein, lots of processed carbohydrates, breads, wraps, pastas, rice, things like that, grabbing food on the go, and then kind of unhealthy choices for snacks. Sedentary lifestyle, she kind of feels like she doesn't really have the time. Her energy is quite low, and when we did screening, she was diagnosed with mild depression. At the 3-month follow-up for her with her family doctor, the HbA1c was even higher than when she was first diagnosed, and so the medical doctor increased her metformin to double what she was taking before, so now 1,000 milligrams 2 times a day. One of the common side effects with higher dose metformin is nausea and kind of this unsettled feeling in the stomach, which, you know, DB is now experiencing. And she was told to change her diet and lose weight, which she was kind of struggling with because she didn't really understand how to go about it. Lots of reading online, very confused, felt it was really hard and difficult to stick to whatever regimen she kind of found for herself. Okay, so when she came in, she to the teaching clinic, she wanted advice on managing diabetes and losing some weight. She did say that she finds making lifestyle changes very overwhelming. It was stressing her out. It was giving her anxiety. And so one of the things I tell my students a lot is start low and go slow. It's okay to take your time with lifestyle changes because it's meant to be a lifetime change. And it's often very hard for patients to go from 0 to 100 and then stick at 100. It's also not realistic for a lot of people, and by all means you're going to have patients who can do it and that's the way they want to do it, and that's great, but a lot of patients can't. And so you want to set very small goals, make sure they're achievable, and really celebrate all of those small goals and steps with your patients. And so SMART goals is one of the many acronyms that you can use to help your patients decide on what their next step is. And so SMART stands for specific, measurable, achievable, realistic, and timely. So we had incremental goals for DB that were decided upon, and we set the stage by telling her that this is where we wanted her to end up in terms of dietary changes. We wanted her to eventually get to a low carbohydrate Mediterranean diet as listed on the screen. And I would say we definitely picked little things here and there. My kind of non-negotiable with her was increasing the fruits and vegetables because, I mean, if I were being really generous, she was probably doing about 2 servings a day when we first met her. And so my non-negotiable was definitely increasing fruits and vegetables each time by a little bit, but she could also try to work on something else, like either doing healthy fats or adding a bit more lean protein or reducing processed and packaged foods. We also let her know that our final goal with respect to exercise was getting her to exercise 3 to 4 times a week at moderate intensity for aerobic activity, and then 1 to 2 times a week of resistance exercise. We gave her other recommendations, the 5 milligram of cinnamon to sprinkle on food, which she really enjoyed, the 1 gram of berberine, which was the gold thread, the Chinese gold thread. This is an extract of it. And we did ended up trying to add some magnesium in, and the reason was because she was starting to feel a little bit anxious. She was having a little bit of difficulty sleeping, and also because her blood pressure was ever so slightly elevated, and magnesium can have a role to play in all of those 3 conditions as well. So we decided magnesium might be a good option for her. We, at the beginning, scheduled monthly check-ins because we wanted to ensure compliance and to also offer support in problem solving anywhere that she felt she was having difficulty achieving. So if she came in and said, I was able to increase fruits and vegetables, but I couldn't decrease the packaged foods, as an example, then we'd be able to ask her, well, okay, so what made it difficult to decrease those packaged foods, and how can we help you? A lot of times patients feel like they either don't have time, so it means finding them or helping them find recipes that are very low maintenance with respect to timing, or also finding healthier snacks, which sometimes patients just don't always necessarily know what those are. Okay, and then at the 6-month mark, she was doing really, really well. She had lost 25 pounds. Her energy is now at an 8 out of 10. Her mood is definitely improved, and her HbA1c is now at 0.069, which just hits the target, which was less than 7. I think both myself and her medical doctor would be more comfortable with if it was a little bit lower than that. And at this point, there was a joint decision to keep her on the metformin at 500 milligrams BID, which is kind of what her original dose was, but less than her 3-month mark, where the dose was doubled. So we brought her back to the original dose of metformin, and she's doing better, has a lot less nausea. She seems to be okay staying on it. Now her goal is to come off of it altogether, and that is something that really depends on the patient and working in conjunction with a medical doctor to see if this is a reasonable option. She's sticking to the low carbohydrate Mediterranean diet about 80 to 90% of the time, which I think is pretty reasonable. She's exercising about 4 times a week. Half of it is aerobic, half of it is resistance. She's going to continue the supplements, and we switched the ND visits now to every 3 months because she's doing pretty good and she's able to problem solve a lot of the concerns on her own now. So the 3-month check-in is just to make sure that, again, re-evaluating whether the supplements need to be there, re-evaluating the metformin, and also making sure that we're helping her adhere to the dietary changes and the exercise changes. Oh, okay. So discussing why I chose naturopathic medicine, or why I would encourage people to choose naturopathic medicine. Maybe I should ask Dr. Yanes, how am I doing for time?
You are doing fine. I would say if we can maybe wrap up in about 5 minutes or so we have some time for questions and answer.
Okay, perfect. Okay, so I think choose naturopathic medicine if you love working with people, because that, I mean, you know, I would say the majority of naturopathic doctors are in full-time practice. There's definitely some who do teaching, but that's also still working with people. They just happen to be students instead of patients. Definitely some naturopathic doctors go into policy and management, and I think that's all absolutely fantastic, but even with policy and management, you're still working with people. I also think, for me, I interpret health is more than just the absence of disease. And so I really do believe making sure that the patient's physical, mental, emotional health are all looked after. And just because your lab numbers are now normalized because you're on a medication, it doesn't mean that you're free of that disease either. So I really do believe that health is an overall thing. And if you want to help people work on you know, prevention, diet and lifestyle, things like that, then I think naturopathic medicine might be a really good option for you. And then the other thing is, you know, you do really have to be willing to put in the work. The programs can be tough, but it is a lifelong learning that you're signing up for. So even after you graduate, you know, even aside from doing the continuing education that you have to do to maintain your license, there's a lot of learning, like developing your practice and, you know, getting better at doing research and refining your skills. You know, I've been practicing since 2009, and I'm still learning on a daily basis, and you really have to be open to doing that kind of learning. Why I chose to focus on cardiovascular disease, mood disorders, and healthy aging. You know, poor diet and lifestyle isn't technically a health condition, but I feel like it should be, because it leads to so many other health conditions if you kind of maintain this poor diet and lifestyle for a long period of time. And so I believe helping patients with diet and lifestyle can prevent cardiovascular disease and mood disorders, and it can also treat cardiovascular disease and mood disorders. And so because I believe that having a healthy diet and lifestyle is so important, I feel like I can play a really big role for patients with respect to these, you know, cardiovascular disease and mood disorders, and also healthy aging. I also believe that healthy living is healthy aging, and you know, a lot of people work really, really hard to save up and plan for their retirement, but if you're not healthy enough to enjoy all of that, I feel like it's kind of unfortunate. And so, it's something that you know, having that healthy living, healthy lifestyle is something that you have to start early and incorporate that into your life. It's not something that you do because you're retired and now you want to be able to, you know, enjoy your retirement, and that's when you go do healthy living and healthy lifestyles. Looking forward, I would love to see more trials on naturopathic medicine, and it's not necessarily testing one supplement versus a drug or one supplement versus placebo. I really do want to see more pragmatic trials, and this is kind of testing naturopathic medicine in real life, looking at the entire system of naturopathic medicine and whether this can help patients with specific conditions. And so I would love to, if I kind of looked at my immediate future, I would love to see a pragmatic trial on depression. I also want to be able to educate other medical professionals on what naturopathic medicine is, raise awareness for naturopathic medicine, and definitely have more integrative opportunities so that we can all work together for the benefit of our patients. With respect to the future of naturopathic medicine, I would also like to see naturopathic medicine in schools. I think we can have a huge role in terms of helping, students in elementary school, students in high schools, universities, things like that. I recently saw that one of the schools, and I can't remember where, but they replaced detention with meditation, and they found that the students did so much better. And I would love to see kind of, healthy mental health practices put into schools, as well as improving the nutrition programs in a lot of schools. And I would really like to see more naturopathic doctors involved in preventative healthcare policies. Advice, I was asked to give advice for prospective students, and I would say find opportunities, conduct research, get comfortable with the concept of research, and definitely learn about business management and contract negotiation. I know that a lot of schools are working on developing this part of their curriculum, but at the end of the day, most graduates will have to learn to balance both being a doctor and also the business side of running a clinic. And only focusing on learning how to be a doctor but neglecting that business side can cause a lot of burnout and a lot of stress, and feeling like you're not able to use the tools that you've learned throughout the curriculum and your years of being a naturopathic student. So I would say definitely get comfortable with those things, and be okay with how you want to practice naturopathic medicine. It is a very wide scope depending on where you want to practice, and everybody, even within the same scope, doctors have a different approach. And the idea is to carve out what feels comfortable for you and how you want to practice it, keeping in mind that we're doing this for the health of our patients. So here's my contact information, and I believe these slides will be provided for you. Research references on the information that we've discussed today. That up.
Wonderful. Thank you so very much, Dr. Wong.
You're welcome.
Yeah, that was really, really fascinating. So before we go on to a few questions, I just wanted to take a moment and discuss AANMC's upcoming events. So we have a webinar on December 7th with naturopathic approaches to anxiety and depression, featuring Dr. Peter Bongiorno. Dr. Bongiorno is the president of the New York Association of Naturopathic Physicians, and well-published. He's written books on anxiety and depression and naturopathic approaches. And then in January, our event is about career changers. So those of you who may be on one path and looking at another one, and how folks do that. So those are our upcoming events. Thank you so much. So with that, I will throw a few questions your way, Dr. Wong,
Sure.
if you'd be so kind. So the first question is, can you put type 2 diabetes in remission without the help of conventional drugs?
I think that would depend on how the level of the HbA1c or how far progressed the diabetes is. It's possible, but it really depends on that baseline factor and how comfortable your patient is at sticking to the diet and lifestyle. You definitely can give the patient a lot of herbs, do all the diet and lifestyle, and that's potentially possible. And I think the one thing that you also have to think about is, at the end of the day, supplements can also be quite expensive. And this is something that I talk to my students about. If the patient can tolerate a lower dose medication and the cost is significantly less than doing a lot of supplements, then it may be okay for them to stay on the conventional medicine. So it really depends on why the patient wants to do this. You really want to examine all of those factors for your patient. I've seen it happen in patients, kind of not needing conventional medicine at all, and being able to monitor their diabetes and manage it. But it comes down to your individual patient, their background risk factors, and you would have to really stay on top of measuring their HbA1c every 3 months to make sure that the interventions that you put in are doing the job that it's supposed to be doing.
Thank you. We have a question about intermittent fasting. Can you speak to that?
I think, okay, so there's definitely been some evidence looking at whether intermittent fasting is a good option for losing weight. That's definitely been published. There are a few smaller studies looking at using intermittent fasting to manage type 2 diabetes. I would be quite hesitant to use intermittent fasting in type 1 diabetes. I know that there's some doctors who do that, and I would say you would have to be working with a patient who's really, really good at staying on top of their sugar levels and making sure that they're monitoring it, especially if they're type 1 diabetes. I think that I would probably be more comfortable doing intermittent fasting if there's more research on it. Right now, hands down, the research or the dietary protocol that has been shown to be most beneficial is the Mediterranean diet, and I'm much more comfortable from that perspective to prescribe the Mediterranean diet. But yeah, I have patients who ask me about intermittent fasting, and if they're otherwise healthy, I tell them definitely let's give it a try, but you have to be honest and good with keeping track of your blood glucose measurements and your HbA1c measurements so we can see how this is progressing.
Thank you. Okay, I've got a few questions coming in here. One quick one, can you put the slide back with your email address?
Oh, how do I?
And another one while you're doing that is it possible to reverse pre-diabetes?
Reverse, sorry?
Pre-diabetes.
That one I would say much more so than once they've been diagnosed with diabetes, because pre-diabetes is slightly elevated blood glucose, and they're at risk for developing diabetes. And I think the last time I looked at the stats, it's if you do not do diet and lifestyle interventions, I think from pre-diabetes to diabetes, it is 100% progression in 5 years. And so that is to say, basically, that you have a window of opportunity to lower that glucose level to get the patient back to a healthier baseline. But that being said, that patient is already at elevated risk of getting type 2 diabetes, which means they have to also be very good at sticking to their diet and lifestyle changes. And also, as their doctor, you would have to make sure that they're staying on top of their HbA1c measurements. But I would say much more likely to normalize at the pre-diabetes stage than the full-on diabetes stage.
So thank you so much. So there's a question here about the type of carbohydrates. And so if you are limiting the amount of carbs, do they need to be slower carbohydrates, or what do you counsel your patients on with the type of carbohydrate?
So complex carbohydrates, and then preferably from starchy vegetables. I still try to limit the amount of processed carbohydrates, and that's going to include, rice, pastas, breads, wraps, anything like that. So I stick to starchy vegetables as a carbohydrate serving or format. And then again, culturally speaking, sometimes it's hard, and then that's okay because you don't want to make it a super stressful thing for your patients. So you would try to counsel them on reducing the amount of bread or pasta or carbs, breads, pastas, or rice, and then increasing the carbohydrates from vegetables and kind of see if you can strike a balance with them. But yeah, to answer that question in a simple term, then carbohydrates from vegetables.
Thank you. Let's see, I've got a couple of questions in here. Getting a little bit specific here, but quinoa, steel oats, and some more whole grains. would those count?
Yes, and honestly, nobody's ever studied quinoa versus steel-cut oats versus regular oats, versus another thing in specifically lowering HbA1c. And I would say, with questions that specific, talk to your patient. The idea is to overall get them to a healthier diet. And if they're really, really, really stuck on the quinoa and that's what they want to eat, then that's okay. Just make sure you're doing all the other things around the quinoa that make it a healthier meal. And it's not to say that quinoa is not healthy, but eating a lot of quinoa, too much quinoa is, well, everything in moderation, right? So too much of anything is not a great idea. So I have patients who are like, I don't mind doing whatever, the fruits and vegetables and the complex carbs from vegetables for lunch and dinner, but breakfast, I absolutely have to have my oatmeal. And that, I think, is perfectly reasonable. Talk to your patients. Make sure you work together with them to achieve something that is sustainable for them. Because if you force them to, in this particular case, never eat steel-cut oats for breakfast, chances are something's going to happen and they're going to go back to it, and then now they may never come back to see me as a patient because they feel like I'm not being flexible, and that's something that's really important to them for whatever reason it may be. So always work with your patients and try to figure out why they're really focused on this particular thing, and see if you can work around it.
Thank you. Let's see. This question is, let's see, are there, gosh, I'm getting a bunch of questions about the education, but I can respond to those offline. I think I'll take one or two more, and then we can call it a day. So there's one here from Gina Marie. I recently read an article that spoke about diet, and it was found that most people eat the same weight of food every day to be satisfied, regardless of where the calories come from. Do you think this helps patients understand how to swap healthy foods for less healthy ones?
So I don't know the exact article you're referring to, but it seems to make sense that if patients need to eat a specific caloric content or weight of food, making sure that we accomplish that using healthier foods seems to be a very reasonable approach.
Yeah. And there's one last question here about diabetic neuropathy.
Okay.
And if you have any recommendations or anything that you've seen helpful for neuropathy.
Mm-hmm. And so a lot of the times, at least in Canada, because for all the naturopathic doctors here are also licensed to practice acupuncture, usually using the ALA that I had mentioned earlier and acupuncture. We've seen some pretty good results with.
Wonderful. And another question here about alpha-lipoic acid and if there are any food sources or only supplements.
I want to say there are food sources, and the reason why we typically use the supplements is because it needs to be at a pretty high dose in order for it to be beneficial, and I would say it's pretty difficult to get that dose, if not impossible to get that dose just from eating foods. So to tend to prescribe the supplements for that.
Thank you. So with that, I really sincerely thank you for coming today and spending a little bit of time and giving us all the wonderful things that are in your brain to us at the AANMC. And I also really appreciate you mentioning the cultural component of diet and exercise. And I remember years ago I saw a patient, she was a Hispanic female, and she came with elevated triglycerides. She was borderline diabetic. There were lots of things that were kind of starting to show up, and she was overweight and she wanted to lose weight. And so we talked about her diet, and and she was this adorable little grandma, and she was just talking about what she ate, and she's like, oh, en la mañana yo como huevos, and like in the morning I eat eggs. Okay, And then, at lunch I'll have a little soup. And she was so cute in the way she addressed everything. And, dinner, maybe some rice, some beans, and blah, blah, blah. And I said, okay, but, in my head, I'm like, well, you're like 40, 50 pounds overweight. So there's more that's being eaten or consumed here than just a little bit of soup and some eggs.
Right.
And so I said, so, do you eat anything with these meals? What about tortillas? And she's like, oh, glad, okay, see, of course I eat tortillas. I said, how many? 18 to 20 a day.
Oh my goodness.
And she was so cute, and she made them, but it was like this family thing, and you talked about the culture, and like she would sit down and she would make tortillas with the family, and so I couldn't tell this woman to like cut out all tortillas, but I said we have to really scale back.
Yeah. Because to her, the tortilla means more than just the food. Like it's an event. It meant something for her family. It was tradition, and so yeah, absolutely.
It was a way she showed love, and so there's so much into that if I just kind of culturally was blind to that and said, listen, you can't eat tortillas. They're made of white flour. They're made of white corn. Like they're killing diabetes. They're not good for your blood sugars. I would have lost her, and so. I think you brought up a very important cultural component that when we're making nutritional recommendations, diet recommendations, exercise recommendations, just in general, that as naturopathic physicians, we're taking into consideration the whole person. And that means their culture, that means their home life, that means all of the wonderful things that make them them. And so for that, I really honor and I appreciate you bringing that up. And that made me instantly think of my little grandma with the tortilla
story.
So thank you so much, Dr. Wong.
Thank you.
Really appreciate your time and hope we can chat again soon.
Absolutely. Take care. Thank you so much for having me. I really appreciate it.
And I will stay on and respond to a few of the questions that are still coming in. Thank you so much for me.
So I'm going to try and hang up. Okay.
Yep. Okay, so I'm going to stay on and answer a few of the questions that are coming in here. And as always, you can come to AANMC.org for any of your questions about naturopathic medical education, and we're happy to help. So feel free to stop by our upcoming events, sign up for our newsletter, sign up to request information from our colleges to stay up to date on what's going on with the colleges, and if you're considering naturopathic school, to start to weigh your options and what schools are the best fit for you. So thanks again for coming. I'm going to turn off my camera and answer a few of these questions and then sign off. So thanks again.